We're with Professor Robert Clancy, who is one of Australia's most senior clinical immunologists and pioneer of the field of mucosal immunology, etc., with 260 publications or more in his career, a practicing professor for more than 50 years. Professor, I am honoured to have you on this program. I'm thrilled to bits that you've given us the time to be on the program. And I wonder whether, Professor, you'd like to just give us a little bit of background on where you're coming from on any issues around the pandemic response.
Well, Russell, my background is this. I'm a clinical immunologist. That means that from a medical point of view, I see people with diseases involving the immune system or where the immune system is not working very well. When I began as an internist, a specialist physician, there was no clinical immunology. So with two others in Australia, we had to create that as a profession. So I've been here basically as long as clinical immunology has been practiced in Australia. It makes me seriously old, I guess, but I still see patients, and I think occasionally I do so with benefit. Now, the second component to my career has been research. And you mentioned mucosal immunology. More than most people, you got the pronunciation right, which is surprising, but good. That's really good. Now, mucosal immunology is about how the wet surfaces of the body cope with infection. So if a virus comes into the lung, then it's met by an immune system. And that's really what I've worked on, the relationship between the pathogen, the nasty virus or bacteria, and the immune system, the local mucosal immune response. And where people have got this wrong, and on the basis I think you wanted to talk about vaccination mainly today, is that in fact, pretty much all the people involved in decision-making didn't seem to understand the basic ABC of how the immune response operates in response to the inhaled virus. And in a nutshell, so that anyone who of your colleagues or friends looking at this understands this, and it puts them in a very prized position compared with most of the decision makers, is that you have two compartments. You have one compartment that's getting infected, that's through the airways in the lungs, and a second compartment, which is the inside of the body, the systemic component. The virus comes into one compartment and the vaccine goes into another compartment. And so right up front, anybody dealing with this must have understood, together with 80 years of experience with influenza vaccines, which have been a very good prototype for the COVID vaccines, must have understood that you cannot prevent infection by injecting a vaccine. You cannot prevent that person with an infection transmitting it because the infection's coming from one space and the vaccination is basically in the other space. Now, having said that, why do we vaccinate? And we have a lot of experience with influenza, and vaccination is a good thing. I'm an immunologist, and for many years I was the go-to person with the TGA and with many other organisations for adult immunisation. So I've been promoting immunisation, vaccination all my working life. That doesn't mean to say that I haven't been critical of some aspects and some vaccines. And I've been extremely critical of the way we've approached the vaccination for COVID. And I'll make one very general point. At no stage was there any evidence or reason for using genetic vaccines for COVID, because they are not ever going to be any better than the traditional antigen vaccine. And secondly, we know about the traditional antigen vaccines. We know their safety record. We knew nothing about the genetic vaccines. And as it's turned out, we now know quite a lot. And what we know is pretty alarming. So that I think is a really very important place to start.
Mm. Now, that's fair enough. Oh, look, this may be an aside, but it may help people too. And on this program, it's not about you and it's not about me, Professor. It's about the people that might be listening to the program. And I read in your screed on you that you understand the relationship between gut health and lung health. Is that right? Do you know? Do you know? Do you know that no doctor has ever said to me, Russell, how's your gut? Never.
Well, my wife has just had COVID, and she'll tell you her gut wasn't very good for a few days, because 15–20% of people who get COVID do get gut symptoms significantly. Now, it's a very good question, because it's something that I've been interested in recent times. In fact, I'm just writing a paper on this, where I'm talking about the communication system between the different mucosal surfaces. Traditionally, what's happened is that there's been an interest for over 100 years in the airway mucosa and in the gut mucosa, but they've been by very different people looking at using very different lenses to see these things. The gut mucosa has dominated the idea of the microbiome. The fact that there are 10 to the 13th, that's 10 by 10 by 10, 13 times, numbers of bacteria in the normal gut. Huge, more than we have cells in the body. And people now, we now talk about the gut microbiome as the new organ. So it's communicating with the body. It's providing factors that can affect the brain. We talk about the brain-gut axis. We talk about the lung-gut axis. And in fact, with COVID, these two programs have all come together. And so what makes most sense is that there's a communication system between the different mucosal surfaces of the body, the lung on one hand and the gut on the other. And that became very clear in COVID, when it was shown that the more severe the COVID is, the more the disturbance of the gut microbiome. The bugs started becoming bad, not good. And there's now very exciting evidence that if you can change those bad bugs back to good bugs, it actually improves the response to COVID and the recovery period of COVID.
I thought there was no cure for emphysema.
Yes, there is. Don't smoke. It's a preventative cure. Don't work in dirty conditions. But we're not talking about emphysema now. We're talking about the lung and the two different organ systems, and how in COVID, COVID's allowed us to bring our ideas, I think, collectively together.
Right. We all believe what we hear, and we trust. Our trust is enormously put in doctors and professionals. Now that has been a sacrosanct place for the Australian people. But I can understand, and I'm very forgiving, if they just believe what's put in front of them by the so-called experts. And this new approach, I'll call it, was not, as you said before, our old-fashioned vaccine. It's a different form. And it was called a vaccine when it actually wasn't a vaccine. I may get that wrong, but it was called a vaccine. And once you call something a vaccine in this country, vaccine is held, in the highest regard for all families and children getting their kids vaccinated, et cetera, et cetera. And there was very, very few times you ever heard of people having a reaction to a vaccine. Very few. The experts may have heard of it, but we didn't as the general public. But recently, over this last 4 years, I have been inundated with people who are, in their terms and what I've seen of them face to face, are vaccine-injured. So right. where a specialist would say, well, I'd see 2 cases of that a year, and I've seen 30 in this month. Now, even the professionals must be saying, hang on, there's an issue here. But I don't see that coming through.
No, it's interesting, isn't it? I don't know all those answers, Russell. I do know that I recently spoke to a group of Australian doctors at an international conference, and I actually called it the 4 furphies of COVID, because I wanted to identify the issues and problems on an evidence-based way. my reception was incredibly negative. I never quite had an audience that had been so less responsive and so unwilling to enter into discussion, because that's all I was really asking for. There's this, it's called cognitive dissonance, where not just doctors, but the bureaucrats, the politicians, a lot of, not yourself, but some of the politicians, and my colleagues and friends in medicine, they say, oh, you know, you're going to talk about ivermectin, you're going to tell us that there's problems with this vaccine that saved the world, which of course it hasn't. Right at the beginning, I was going to go on to what's good about vaccines, because we don't want to think for a moment that everything is negative about vaccines. So would you like me just to go in that direction a little bit?
Yeah.
Why? Because I think people might be wondering, if I'm talking about two compartments and the virus infecting one and the vaccine affecting the other, why on earth are we giving vaccination? The reason we're giving vaccination of any form, be it a traditional antigen vaccine or a genetic vaccine, as we have been doing, the aim is to stimulate, like putting a cloak of protection around the lung, to stop the COVID virus getting out of the lung. Because when the COVID virus gets out of the lung, it moves from one compartment to the second compartment. And so if you've got immunity in that second compartment and you put this cloak of protection, then that is going to prevent or reduce the chance of more serious disease. So serious disease is when the virus escapes from the mucosal compartment. And that's where the antibodies in the blood, which you measure and say, oh, we've got an antibody against the spike protein, that's where it is supposed to work. Now, and that's what it does. And if you look at the flu vaccine program, you look at COVID, the aim is not to prevent infection, not to prevent people transmitting infection. And that was a terrible, terrible misunderstanding by the people who should have known better, and they should have known better. Lockdowns, all those processes were based on preventing transmission of infection, which does not occur. We now know, everyone I think pretty much understands that now, but they should have known it earlier from the history of biology and the history of influenza vaccines. So why give it? You give it because you want to reduce serious infection. And I think if you look at the bulk of data, and it's argued, it's not crystal clear, but by and large, there's a body of data that says, yes, with the current COVID vaccines, you do reduce the severity of infection. Maybe, certainly early on in the infection, perhaps not now so much, because there's been too many, if we get onto the problem of too many vaccines, too many vaccinations. But the aim was to stop this virus getting out. And the monitors of that were two. One was admission to hospital, and the second was death. Now, this is argued all around the debate, but there's probably some truth to the fact that there is a protection against serious disease, although there's never, ever been a randomized controlled trial, which everyone is very happy to level at some of the drugs that have been used, but don't want to admit that it's never been used for serious disease. Now, that is only one side of the equation. The value of the vaccine has to take into account comparing the degree of protection against the amount of adverse events. And when this has been done it was first done on the actual Pfizer and Moderna data. You know, remember that data that wasn't allowed to be, it was going to be held up for 75 years and court let it out. Well, when that was analysed independently, it was shown that there was a significant difference between the degree of protection and the amount of adverse events. The adverse events trumped, sorry, that's the wrong term to use these days. The adverse events were greater than the degree of protection. More people were going to hospital with adverse events than they were not going to hospital because they were protected by the vaccine. And when that type of analysis has been done, and this has come up repeatedly over and over again, that the damage effect is greater than the protection effect. And then when you start looking at who gets the problem, and you find that, and I just saw this data the other day, it's hard to believe, but apparently true. Not one well child in United Kingdom and the United States went to hospital as a result of COVID infection. Not one child, not one healthy child. In other words, the whole vaccine program for children was, if it wasn't serious, it'd be a giggle, because those kids didn't need the vaccine. It didn't stop them transmitting the vaccine or getting infection, but it did create some pretty serious side effects.
Yeah, that's transmitting the virus. You just said vaccine then, but transmitting the virus didn't stop them. And I remember the head of the Children's Hospital here in Melbourne saying, yes, we have one child in the hospital with COVID, but she's not in because of COVID. She has a broken arm.
That's exactly right. And the other kids there, because both the parents were very sick and they had to park the child somewhere. That was happening in.
So, without getting you into trouble, and I don't want to, what you said is pretty damning. That people in senior positions actually took their eye off the ball and believed whatever was being put to them by whoever.
Yeah, how can I respond to that? Well, certainly,
you don't have to. Yeah. By the way, I'm not here to condemn the doctors and physicians and politicians and bureaucrats that made these decisions, because of the fear campaign that was thrown at them at the time around the COVID pandemic, that they made decisions they thought were in the best interests of their nation. I have no doubt about that.
I agree with that.
I do condemn the people that gave them the information in the first place, though. I sure do.
Yeah, well, you're getting close to some big international organisations, aren't you?
Yeah, but I'm not going to name them. I'm not going to say anything. But from childhood, I was a questioner. As a politician, as a business person, I was a questioner. As a politician for these 25 years, all I've done is ask questions. And if that offends people, Professor, I've got to say to you, you arrived at the top of your tree because you're prepared to ask questions of the system, and it's called science.
Yes, well, it's interesting, isn't it? Very interesting. I don't know how to answer, Russell, those sorts of questions, because many of these individuals are lifelong friends and colleagues of mine. And I think the power of persuasion, the power of imposition of something that we never asked for, we never needed. I personally think that what went really wrong was that we lost our independence. If you look at the way we've coped with pandemics for 120 years, we've independently faced them and solved them.
You're saying it's been an Australian reaction.
Exactly.
And there was a plan, Professor. There was a plan developed by people like yourself.
Well, that's true. That is true.
For the nation.
There was an influenza plan that was most updated in 2019, just before COVID. We all expected the next pandemic to be influenza, although, you know, there was the precedent of two types of COVID rogue viruses earlier in the 21st century. But we didn't get influenza, we got COVID, which behaved very like it. And immediately, the right people changed the plan from the influenza one and the COVID one. I think it was February, March of 2020, we had the COVID plan. 2-3 months later, it was all out the window.
Out the window. And look, this brings me to another point. Have you had any pushback from your friends and colleagues? Because I have a lot of people in very high places who were brilliant in their field one day, you know, a leader in the hospital, a leader in nursing, a leader in their chosen academic place in medicine and health. And the day after, they're a nitwit because they're not going along with the narrative. They question the narrative. How can it be that you're a highly esteemed colleague one day and the next minute you're a crackpot?
Well, I don't know. What's your answer to that, Russell? It's outside.
I can't believe everybody went in the same direction as they did. I mean, when I was first told about it, I was told that we were going to turn the major exhibition centre in Melbourne into a morgue. That's the first time, but I had to keep that a secret. Now, as far as I'm concerned, that was the truth. But that was talking about the illness. That wasn't talking about the vaccines. The vaccines we weren't talking vaccines then.
Yeah.
And that would have been 2019-20, wasn't it? Vaccines were 20 and 21, is that right?
No, vaccines came, in 20, basically for us in 21, 22, yeah.
21, 22. That's a long time after Bali was experiencing an influenza outbreak in 2019. And I knew from what people had told me, Professor, that you don't vaccinate after you've got the illness.
Right. I think let's go back to...
Well, you don't normally vaccinate in the middle of a pandemic. That's
vaccination. Let's look at exactly that, because it does lead into one of the biggest issues. That when I talked about two compartments and I talked about the mucosal department, the elephant in that room is the down suppression of immunity. You imagine that you've got a lung and you've got all these bacteria. If you make a vigorous immune response, it's like a grenade going off. You blow your lungs up. One bacteria gets in the bloodstream, that can cause septicemia and kill you. So you need to have very different objectives of the two types of immune system that I talked to you about. The immune system in the mucosa needs to control. The immune system in the bloodstream needs to be sterile. That's the difference. And so the way you can get the control is through a special type of cell that turns off the immune response. It's highly efficient. So every time you immunize somebody who has been sensitized by the COVID-type viruses they've had over the years, you have two types of cell in the body. You have a positive one that's going to do things and a negative one, which is going to turn it off. And as you progressively give vaccines, you progressively turn off the immune response. The net response is a negative one. That's been amply shown with COVID. Where we went wrong in COVID was a panic reaction to first of all, genetic vaccines should never have been started because of the complications and the disturbance of genetics, which we still haven't analysed. And you've been bringing up the quality control processes, which are critical. So let's have a look and see what happened. That we had, how good is a vaccine when you need 5 within 12 to 18 months? It can't be a particularly good vaccine when you have a tetanus vaccine that lasts you up to lifelong. So there's something wrong. Now, we knew about this because we know that if you have a flu vaccine this year and you had flu as well, when you give the flu vaccine next year, there'll be a 20% reduction in the amount of protection you get measuring the antibody because you get this negative effect. When they looked at one of the major clinics in America, where they employed something like 30,000 people, they found that after the first booster, that's the third vaccine, the response was negative. These people were getting more infections. This is not my data. This is published data from the Cleveland Clinic. Everyone should know about it. And so after 3 vaccines, not only were they not getting more than perhaps a blip of protection for a few days or a week or so, they were getting negative infection. And I can tell you and your viewers that if I say to you, what happens if you go to an allergist and you have lots of problems by inhaling in pollens? What sort of treatment does he give you? He gives you injection treatment. He gives you 3 or 4 or 5 injections to turn off that immune response. The lungs look at the virus in the same way they look at a pollen. So you're actually giving desensitization therapy to somebody because you're panicking, you don't understand the biology, and you're turning off the net immune response. So even if you're going to be having these vaccines, particularly now, what we're getting is progressively less protection for longer periods of time, so that ultimately you're going to get protracted proneness to recurrent infections and possibly more serious infections. They're facts. They're facts.
That's a pretty serious thing to say, Professor.
It's true. It's true. Now, this is all published data. This is not me or my theories.
Right. Well, that's important because we can't, one of the things that I must never do, and number one, I've never given advice to anybody as what they should do with their own body. I've never said don't go to your doctor or don't go to your specialist or don't go to your naturopath or don't go to whoever provides your health service. Never. And I wouldn't tell somebody not to get a vaccine if it's recommended by their doctor or whoever they trust. But I do ask questions. And I thank you not for the work you've done for 50 years that puts you in a position to be able to speak with authority when you have read the information that has been put before you. But I thank you for your bravery and encouragement to people like ourselves for doing the research and knowing what research is available, but more important than that, for us lay people to understand what the research and this is actually showing and being able to communicate it to us in the way that you have today. I am most appreciative.
Let me just add a rider to what I've just said. If you were talking to some of my colleagues who know this data from the Cleveland Clinic, they'll say, yes, but that's infection, but you still get some protection against more severe disease. So a lot of people would say that with the third shot, you're going to get protection, and you do for a short period of time. But this time where you get protection against more serious disease, like the infection rate itself gets progressively less and less. And so we need to look, no matter what vaccination you decide to go with, the spacing of vaccines. And also the virus has moved on a long way from where the current vaccines are. So you're getting less and less. And there's some recent data suggesting that what you stimulate, the antibody, you actually stimulate the memory for the old virus rather than the new one. So it's very complicated, very difficult, but never, ever been properly sorted out.
And to my knowledge, never, ever properly been tested. Professor, thank you for all that you do, and thank you for being on the program today. We greatly appreciate it. We wish you all the best.
Thank you very much. It's been a great pleasure, Russell. And thank you for the work you're doing on quality control, which is absolutely critical.
Correct. Thank you.